Good afternoon, everyone. Let me just make sure that we're live because there's usually a notification that we are. Good afternoon, everyone. I'm Dr. Kim Newell-Green, and I'll be the moderator for the virtual Grand Rounds today, entitled Infectious Disease Updates from the California Department of Public Health. As I read the newspaper this summer, I've been eager to hear from experts that we've assembled today because several questions loom. Is COVID-19 re-emerging as a threat, as the headline suggests? What about West Nile virus this year? And isn't there a new RSV vaccine? Who should get it? In this virtual Grand Rounds, Erica Pon, MD, MPH, will give us the latest updates on COVID-19 and other topics, as usual. And we have some wonderful experts from the California Department of Public Health who will present information about mosquito-borne illnesses and the latest ACIP Advisory Committee on Immunization Practices updates, including information about the new RSV vaccine and other issues. Next slide. Oh, no, this slide. Back here, you see our disclosures for our speakers today. Next slide, please. This is our agenda for today. Next slide, please. And just as a reminder, we do offer CME for this series. And so please do fill out the survey at the end of the talk today. I also want to acknowledge CDPH is a wonderful partner in providing relevant public health education for the physicians of California. And just as a reminder to our viewers today, with the end of the public health emergency, we're pivoting from focusing primarily on COVID-19 to address all public health topics that are emerging and relevant to California physicians. We've received such great feedback about how this series previously helped you all in your practices, and we hope to continue to be able to do so by addressing more public health issues broadly. So please let us know if there are issues that you want to hear about. Next slide, please. As usual, I'm happy to bring back Dr. Pon, our California State Epidemiologist and the Deputy Director for the California Department of Public Health Center of Infectious Diseases, to give our state epidemiology update. Take it away, Erica.
Great, thank you so much, Kim. It's a pleasure to be back. I think I missed last month, but happy to be back with all of you today. Let's go ahead to the next slide. So today I thought I would do my usual kind of what's going on with COVID, what's our state data looking like, and of course it's back to school time. Many where I live, Oakland Unified just started back this week actually, so I wanted to talk briefly about some back to school just awareness and updates, and I have just one mini update at the end about Mpox. Next slide. So we continue to maintain our dashboard. There have been some minor changes over the last couple months as we have shifted from really trying to adopt our COVID-19 surveillance into our broader surveillance, but we do maintain this. And we changed some of our data feeds for hospitalizations, but we are seeing we had sort of a nadir this past summer, and it stopped dropping and started to increase a bit, although our 7-day averages are still relatively flat, and I'll show you a larger perspective on that in a moment. And thankfully, our deaths remain extremely low as far as our death rates. And we have seen test positivity go up, certainly in the last 2 to 3 weeks, and I'm sure many of you are anecdotally both hearing about friends and family and colleagues, as well as seeing hearing more about some more circulating COVID, which, a lot of this may be from summer travel and other things, but again, thankfully our hospitalizations are looking very reassuring so far. Next slide. And we are seeing some of this trend nationally as well. So hospitalizations have been creeping up just a bit nationally. Deaths have also been stable. So very much mirroring that. And nationally, they've been noticing some slight increase in ED visits as well. Our ED visit data is not as good, so we don't have that publicly available, and we're kind of still looking at how to best monitor that. Next slide. So just thinking back and, thinking about from the beginning of COVID-19 as pandemic to now, just remembering that we do typically have had a very big winter surge and then often a summer surge as well. So we've had these sort of twice-a-year surges historically over these last 3 years of COVID-19 in our presence, but we did last winter again see a peak similar to the sort of summer surge the year before, but thankfully, as you can see here, this is the CDC data. It has continued to drop, and again, maybe plateaued, maybe a slight increase again, but at historical lows. And then if you click again to the California data, this is our California data, which you can also still see on our dashboard, and you can see very similar trends in California as well. And again, these historical lows. We have, you know, at all of these naders historically as well, when we've been under 1,000 total hospitalized patients, that has been very low. And again, there might be some slight increases. I think it's a little bit hard to compare as well, just knowing that there's less and less screening for COVID that's going into hospitals. Whereas, you know, before we know that there are many people who are incidentally tested, I think that is decreasing as well. So it's a little bit hard to compare, but I think, again, reassuring to see that despite some increases in test positivity and increase in cases, we are not necessarily seeing more severity. Next slide. The other thing, of course, that we are continuing to watch closely, especially given most of this testing that happens at home and individual cases are no longer reportable, we are looking at trends by region with our wastewater. And you can see again that in all of the parts of the state, except the Central Valley, we are seeing the wastewater levels at sort of a medium level, and just the week before they were all at low except for one region. So starting to see some increases, and again you can see these historical trends in these different regions here, and that it's just creeping up into that medium area, and that's kind of the medium third of historical precedent. Next slide. And then what variants are we seeing, of course, is the other big question. So we still see largely XBB 1.5, and then the one that is increasing the most, you may or may not have been hearing a little bit in the news about this, is EG.5, which is essentially a sub-variant of XBB. It is continuing to increase. It's about 12-ish% of what we're seeing here in California and similar trends nationally. There's nothing, you know, there are a couple mutations on this particular variant that, you know, may have more immune evasion again, but it is very similar and still a sub-variant of Omicron. So, you know, the new vaccine that Dr. Chen will talk about later should still have good cross coverage because it's still based on the XBB base. Next slide. And then, you know, as we think about back to school, there's just a few things wanted to highlight. We do still have a lot of over-the-counter testing available for schools. We've distributed information to all of the public school districts, and we do still have this year a lot of tests that schools can order. So if they want to have those for back to school or back from breaks, or certainly if they have any kids with respiratory illness in the school. So there's a lot of links on our Safe Schools for All website on how to order those. Many school districts already have been in the practice of doing that before. And then very soon, we hope to have approved a couple of different guidances for schools. One on just general sort of respiratory illness guidance for schools, and also some symptom-based guidance that has really been a great product of a lot of the collaboration and close collaboration with the California Department of Education and school nurses and AAP and others to really help us think about what are really useful for schools and for school staff on the ground to help think about communicable diseases in the school setting. So those should be posted very, very soon in the next few weeks. We're still finalizing all those approvals, but stay tuned on this State of California Safe Schools website, as well as our CDPH website. Next slide. And then the other thing wanted to just highlight is it is actually HPV Vaccine Awareness Week. And many of you probably likely know that HPV vaccine is one of our most effective vaccines, yet we have really low vaccine coverage with this vaccine. So you can see here, you can highlight and compare to Tdap and meningococcal coverage. You know, we have over 80% coverage. That's been increasing and improving over the years. And then we've had some increases in both at least one dose of HPV versus that up to date. But if you look at how many are up to date, you know, based on recommendations, and this is through 2021, you can see we're barely at 60% nationally as of 2021. And we really want to do better. And here's some of the reasons why. Next slide. Actually skip to the next slide, and then I might have you go back for a moment if you want. So here's some really important facts for you to remind your patients and remind yourselves. This is a vaccine for cancer prevention, and that's really how you should be talking to your patients about this. It causes 6 different kinds of cancer, at least, that this vaccine can protect people from, and it's very safe, and again, over 90% effective for this HPV cancer prevention. And people kind of forget too that HPV causes more mouth and throat cancers than smoking. So this is a really important, again, cancer prevention vaccine. 79 million Americans are infected, and it's really best to get your kid vaccinated at this 9 to 12-year-old age range. That's the best timing for it to be the most effective. So if you go back one slide, if you don't mind. Sorry for changing my mind in the order. So again, it is California HPV Vaccine Awareness Week. We've gotten even a governor's declaration about this, and a lot of great campaigns and partnerships that have happened with the California HPV Vaccination Roundtable, CDPH, the Immunization Coalition is where that other graphic came from. And so there's a lot of great toolkits, and you should see and keep your eye out for a lot of social media around this as well to really remind parents to get their kids vaccinated, and all of you as providers. There's some providers resources as well. There's actually a webinar tomorrow that I don't think I have the link on here for, but we can make sure we send out to people if they're interested. So we really want to increase awareness and get those vaccination rates up in our teens. Next slide. And then finally, I just wanted to end with some people have been asking about or wondering about what's happening with Mpox. We certainly weren't sure what would happen this coming year. As you all may remember, last May is when we declared Mpox a public health emergency in California and nationally. And you can see this huge peak we had last summer. And thankfully, due to getting a lot of people vaccinated, I think there were also some harm reduction behaviors and of course natural immunity that may have occurred from prior infections. We have really seen a dramatic decrease. We have seen some increases. There was a cluster in Chicago, a small cluster in Los Angeles, here in California. And you can see, again, if you see the pullout here from the last 8 weeks, we had some blips here and some increases in cases after some real lows and, less than a case per day, but we still are having actually less than a case per day. So thankfully, again, I think a lot of good education, harm reduction, and vaccination. We really want to remind people, though, to get that second dose of vaccine. And we'll continue to be vigilant on the heels of, Pride Month in June and lots of other events that are upcoming, making sure we continue to get people vaccinated that haven't been vaccinated and good messages out. But wanted to sort of show that this is a good testament to being able to resource a public health outbreak and epidemic and being able to get vaccinations out. And thankfully, again, this summer we've not seen a large increase. Next slide. So with that, I will pause and just again note that not only is it HPV Vaccine Awareness Week, but it's National Immunization Awareness Month, which is a good way to segue to Dr. Chen, and she can give you a lot of the updates from ACIP. So thank you all, and have a good beginning to your fall and end of your summer. Thank you.
Thanks so much, Erica. And welcome, Dr. Chen. First of all, I'll just say, Erica, it's always so reassuring to have the data instead of the newspaper headlines. But I also want to preview that on September 12th, we will be doing this conversation here about those new school guidelines on communicable diseases with a whole lot of the folks who actually created those guidelines. So please join us for that as well. Now, I'm very, very excited to introduce Dr. Jenny Chen. Dr. Chen is a public health medical officer with the immunization branch of CDPH. She's a board certified internal medicine, pediatric, and preventive medicine physician, and she'll give us some updates on vaccines. So thank you, Jenny.
Thank you, Kim. Next slide, please. So we're going to review some of the ACIP updates. Next slide. So the CDC has this advisory for Committee on Immunization Practices, which we shortened to ACIP, and they have a large meeting back in June and then a recent meeting last week. Lots of topics were covered. You can see them all on the slide here. The ones that are in bold are the ones that we're going to be covering today. It's mainly those vaccines that are preventing respiratory diseases. Next slide, please. So for the COVID-19 vaccine updates, during the meeting, they discussed the epidemiology, the current epidemiology at that time of the COVID-19 vaccine effectiveness, and also infection-induced and hybrid immunity. But there were no votes yet on updated recommendations, as they're waiting for FDA authorization on a updated vaccine this fall, the monovalent XBB strain that we can talk about a little bit. Next slide, please. So in terms of policy considerations for this updated vaccine this fall, the FDA's group, the Vaccines and Related Biological Products Advisory Committee, or VRBPAC, they met and voted back in June to recommend an update of the COVID-19 vaccine to a monovalent XBB.1.5 lineage. And then the anticipated next steps would include, they're sort of highlighted in this figure, that the vaccine manufacturers will be making this XBB.1.5 containing product, and then the FDA will authorize it or provide licensure, and then subsequently after that, the CDC and the ACIP will meet to discuss the recommendations for its use. Next slide, please. So in the meanwhile, there are no changes to FDA or CDC guidelines. It's recommended to continue administration of the bivalent mRNA COVID vaccines. The reasons for this is that they were studies reviewed during the ACIP meeting that the bivalent vaccine still protects against severe COVID-19 disease, and even from those currently circulating XBB lineage variants. And those who receive the bivalent mRNA are still expected to likely be eligible for the new updated vaccine this fall. Just a reminder, there was a group called the Western State Scientific Safety Review Work Group that in the past had reviewed some of the safety data regarding the COVID vaccine, but that has been disbanded. So any recommendations will be coming from national sources like the FDA and CDC, and those will be what will be recommended in California as well. Next slide. And so we're going to transition a little bit to influenza. There was a discussion about influenza vaccine back in the June meeting as well. The second vote is about affirmation of the MMWR and the actually the strains that will be included in the flu vaccine this year. And this year there's going to be an H1N1 strain. And then vote number one was unanimously approved by the ACIP, and that's that all persons aged 6 months or older with a history of egg allergy, regardless of severity, should go ahead and receive any of the influenza products. We'll talk about that a little bit in the next slides, but just to let you know that the CDC director endorsed this recommendation about the flu vaccine, and there should be an MMWR publication with more details expected sometime this month. Next slide. Okay, so just to go a little bit more, to give a little bit more information about that first vote, there were as I said, there were several studies that were reviewed that reported on the flu vaccine safety for persons with a reported allergy of any severity. And basically what those studies showed was there's very rare occurrence of severe reactions to flu vaccine. So these new recommendations are actually in alignment with the American Academy of Pediatrics and National Allergy and Immunology Society guidelines that advise that no additional special precautions beyond those recommended for routine vaccinations are needed for those with a history of egg allergy to receive any of the upcoming influenza vaccine products. Next slide, please. We're covering a lot of topics, so I'm transitioning a little bit quickly, but now we're going to just review a little bit about and compare a little bit about RSV and influenza. This particular graphic is showing the burden of disease and what it causes in terms of the population of adults who are 65 years or older. The left-hand grayish pyramid is RSV, and the right-hand bluish pyramid is influenza. And you can see that the rates of deaths per year, hospitalizations, and symptomatic disease per year are similar. And so as with flu, adults with chronic conditions and elderly adults are at greatest risk for severe disease from RSV infection. Next slide, please. So the next slide is just now looking at the burden of RSV hospitalization and deaths and comparing them between the older adults and children. You can see that on the left-hand side for older adults, the absolute numbers are higher than in children. These are children less than age 5 years. But just to keep in mind, RSV is the most common cause of hospitalization in U.S. infants, and those the younger ones, the newborns up to a few months, are the ones that have the highest hospitalization rates. The rates do decrease as babies get older, infants get older. Those who are babies who are prematurity and have prematurity and other chronic diseases, they are at increased risk of hospitalization from RSV, but actually most of the hospitalizations are actually in healthy term infants. Next slide, please. So this is just a summary of some of the RSV prevention products that are available or coming down the pipeline. The left column is there are 2 RSV vaccines now approved and recommended for older adults. And then on the right column, there are some products that are available for infants and toddlers. There is no RSV vaccine for kids specifically. There is one that is being studied right now. That's the first one, Briscoe, that is, they're looking to protect pregnant persons and women, and then ultimately their newborns by passive immunization. There are 2 monoclonal antibody products, the nirsevimab and palivizumab, which are offering passive immunization to infants. Palivizumab has been around for 20 years, and that's been available to protect high-risk infants. There's a new product called nirsevimab, which is approved actually recently, and this is actually for all infants. Next slide. This is just a little highlight also to review how products are sort of approved and the process that they go through. So this past year, RSV products have been quite busy. The company's been quite busy. So in May, FDA approved 2 vaccines for the older adults. And then in June, CDC met and the ACIP recommended these 2 products, and we'll go a little bit into what the recommendations include. Then in the past month and a half or so, the FDA approved nirsevimab, which is the monoclonal antibody, and then just last week, the ACIP met and recommended the monoclonal antibody for infants. In the coming months, we're anticipating there may be an FDA approval for RSV vaccine for maternal immunization. And if that does happen, then the ACIP will likely meet to discuss recommendations for its use. Next slide, please. So this slide is just a little bit more details about the vaccines that are available for older adults. And these are older adults are those persons who are 60 years or older. There are 2 companies that have made RSV vaccine. They're both 1 dose, it's an IM injection, and they both have shown to have greater than 80% efficacy in reducing the risk of RSV-associated lower respiratory tract disease. Next slide. So during the meeting, what the committee voted on was they basically broke it down by age, and both age groups, those 65 years and older, and those between 60 and 64 years, were recommended that they may receive a single dose of RSV vaccine using shared clinical decision making. There was, a big discussion about these votes, and some of the details and topics we'll review a little bit in the next couple of slides. Next slide. So last month there actually was published in the MMWR full recommendations for these vaccines. And so what clinicians should offer is a RSV vaccine to adults aged 60 years and older using clinical decision shared clinical decision making, and whenever the vaccine becomes available, and it's acceptable to co-administer these vaccines with other adult vaccines. Next slide. So the rationale for the recommendations are a balance between vaccine efficacy and safety profile. So this slide is meant to discuss some points that were actually points of discussions that they had during the meeting, and in terms of how they ultimately came to this recommendation. So vaccination with a single dose of RSV vaccine demonstrated good efficacy in preventing lower respiratory tract disease caused by RSV infection. And this was in a group, the population of 60 years and older. The trials were underpowered to estimate efficacy against hospitalization and death, although there was suggestion that it would prevent morbidity from RSV disease. Both vaccines are well tolerated and had acceptable safety profiles. There were a few cases in each vaccine product of serious neurological conditions, including Guillain-Barré syndrome or GBS. And this has been very rarely reported after vaccination in the trials, but it wasn't clear whether the vaccine actually caused these events. So there will be continued post-marketing surveillance over the next year or so, and this is to help clarify whether or not there is any sort of safety signal or any potential risk. So given these findings, the RSV vaccination in older adults should be targeted to those who are at highest risk for severe RSV disease and therefore most likely to benefit from vaccination. Next slide, please. So just wanted to give a little bit of more information about what is shared clinical decision making. ACIP and CDC do have a website that gives recommendations on how this can be done. There's a link on this slide. So for RSV vaccination, the decision to vaccinate is based on a discussion between the healthcare provider and the patient, and there are several topics that might be discussed in regard to whether or not your patient would be somebody who would benefit from RSV vaccination. There are some populations of persons who might be at higher risk of disease, severe disease, and those would be persons with chronic medical conditions, those who are frail and who are of advanced age, and residents of congregate settings. But just to let you know, those last two groups, there was limited enrollment of these populations in the trials. So there's not a lot of information about the benefits, but there's sort of extrapolation that this would be beneficial for these two groups of populations of people. Next slide, please. If you're like me, I do better with visuals. So this is just a graphic in terms of those populations or groups of people who might be at higher risk of RSV disease and might be gain benefit from the vaccination. Next slide. So now we're going to transition to nirsevimab, which is again the monoclonal antibody that offers passive immunization for infants. So last month, FDA approved this product, which is a single intramuscular injection, and it's used to prevent RSV lower respiratory tract disease. They looked at two populations, all neonates in their first RSV season, and those aged less than 2 years who still might be at risk for severe RSV disease and into their second RSV season. So there are studies that showed that this was safe and efficacious and that the side effects were minimal. Next slide, please. So last week, the ACIP actually held a meeting to discuss nirsevimab, and they had 3 votes, and which were all approved. The first vote is that infants aged less than 8 months, born during or entering their first RSV season, are recommended to receive a dose of nirsevimab. And then those children who are between 8 and 19 months who are at increased risk of severe disease and entering their second RSV season are recommended to receive a dose. And the criteria for those who are at risk of severe disease has been provided by the American Academy of Pediatrics for use of palivizumab in the past, and we're anticipating that that would be the same group of children who would also be recommended to receive the dose in the second season. The last word was that this product would actually be part of the Vaccine for Children's program, and later that afternoon, actually the CDC director adopted these recommendations, and so the MMWR with details on the recommendations will be upcoming at some point. Next slide. So we're going to transition to talk a little bit about pneumococcal vaccine, which is a vaccine against diseases caused by Streptococcus pneumoniae bacteria. In California, invasive pneumococcal disease, which is IPD on this graph, and in children that are under 5 years old is reportable. So this is some surveillance data from California. And the x-axis or the bottom is the timeline, and the y-axis the incidence. And since PCV13 was recommended for use in 2010, so the far left is 2011, you can see that the rates of IPD have been going down steadily. The last year on this graph is 2021. This is measuring the serotypes, or this is actually data on the serotypes of pneumococcal that are being found in these cases of IPD. And the top shaded dark blue area are pneumococcal serotypes that are actually not covered by the vaccine. So that's still a pretty large group. In the very bottom lighter blue shaded areas are the serotypes that are covered by the PCV13. And so that actually has been going down pretty small amounts at this point. The gray shaded area are the serotypes that are covered by PCV20 and not covered by PCV15. And so the red squared highlighted percentages are showing that by using or administering PCV20, you can afford an additional 13 to 15% against IPD cases. Next slide. Okay, so in June, there was discussion about pneumococcal vaccine and specifically PCV20, and there were 4 votes. So the first 2 votes are highlighted in this slide. It's basically voting to recommend use of PCV20 or PCV15, which was just approved actually last year, either or for routine immunization for all children less than 2 years old. And the vote 2 is that allowing the use of PCV20 as catch-up doses for kids who have missed their immunizations at less than 2 and are up to 5 years old. Next slide. Okay, and as you probably all are aware, pneumococcal vaccine schedule is pretty complicated. The vote number 3 is allowing use of PCV20 as one of the possible vaccines used for those kids who are age 6 to 18 who have a risk condition. And there's a list of risk conditions, and those will be published in the MMWR. And lastly, vote number 4 is that PCV20 can be one of the products that is available for use in the VFC program. So all of these votes were approved, and the full recommendations will be published in MMWR. That's actually probably anticipated to come later this month, actually in the next several weeks. And it's anticipated that the recommended schedule for this PCV20 in children will be simplified and be similar to the now adult PCV20 vaccine schedule. Next slide. I think that's the end of my talk. Thank you very much, and I'm passing it back to Kim.
Lovely, thank you so much. A lot of information in that, so we're really grateful to hear the updates. And now I'm very excited to introduce our next speaker, Dr. Mary Beth Danforth. Dr. Danforth is an epidemiologist with the California Department of Public Health in the infectious diseases branch as well, where she's a subject matter expert on mosquito-transmitted diseases. And lots in the news about this as well, so excited to hear from you today, Mary Beth. Take it away.
Let me unmute myself. Thanks for the introduction, Kim. Next slide. So I'm going to try and do a broad coverage of several mosquito-borne diseases in California, starting with our locally transmitted mosquito-borne diseases, West Nile virus and St. Louis encephalitis virus. Next slide. So both of these viruses are flaviviruses. They're very closely related genetically. They are transmitted by mosquitoes from the same genus Culex and maintained in the same avian mosquito cycle. However, West Nile virus is by far the predominant mosquito-borne virus, and in fact is the most commonly reported vector-borne disease in California, and has been since it was first broadly transmitted across the state in 2004. For the last 5 years, we've had an average of about 200 cases a year. However, we recognize that some of those numbers recently might have been suppressed by some of the pandemic efforts. Transmission is pretty broad spread across the Central Valley and Southern California. Los Angeles reports the most cases each year. However, our highest incidence is in the Sacramento Valley, the northern part of the Central Valley, in the rice-producing areas such as Glenn and Butte County. We do get cases reported from coastal and mountainous counties where there's very rarely environmental activity. Those cases are most often associated with individuals who travel to other parts of California or other regions in the US, which does have less Nile virus transmission. In particular, we get a lot of people who play golf and go down to Arizona to play golf in July, which is not a choice I would have made, but I'm not a golf player. So next slide. Clinically, since these are very closely related viruses, they actually, according to the CDC reporting, have the same case definition. So clinically, the majority of cases that we are reported in California are neuroinvasive disease. They are characterized by meningitis, encephalitis, acute flaccid paralysis, or other signs of central or peripheral neurological dysfunction, such as Guillain-Barré syndrome. We've had an increase in ocular involvement recently, as well as an absence of more likely clinical explanation. Now, neuroinvasive disease actually only represents less than 1% of all infections, but due to the severe and often fatal presentations, it does get diagnosed most often. Only 25% of cases roughly reported in California are non-neuroinvasive diseases cases, though actually there should be 30 to 70 non-neuroinvasive cases reported infections for every neuroinvasive case, but we don't get as many as often. These are much more flu-like. The only required symptom that CDC requires for reporting is fevers or chills, as reported by the patient or a healthcare provider, as well as absence of neuroinvasive disease and absence of a more likely clinical explanation. Other typical symptoms or frequently reported symptoms include headache, muscle aches and pains, occasionally rash, diarrhea, nausea, and vomiting. Next slide. Diagnosis of these viruses is most often based on serological testing. The most common initial test is IgM detection. It is widely available commercially and at local public health labs for West Nile virus. There is very limited commercial availability for SLE. That is less of a concern because there's a lot of cross-reactivity, and so most SLE patients are actually initially reported as West Nile virus patients. Testing is most sensitive in serum samples, so it is a preferred sample for serological testing. Cerebrospinal fluid, or CSF, is only appropriate for suspect neuroinvasive disease patients. I'm not a clinician, but I presume that if you are doing a spinal tap and getting a CSF sample, you are suspecting some kind of neurological involvement. However, there's just fewer antibodies in those samples. And as I mentioned earlier, it cross-reacts with other flaviviruses, so not only SLE and West Nile virus, but also dengue, Zika, as well as yellow fever, including the vaccine strain. So please, when possible, take into consideration potential travel history of your patient, that they may actually be infected with one of these other strains. PCR is rarely used for symptomatic case patients because most often the viremia falls off before a patient develops sufficient symptoms and seeks healthcare. However, it is an appropriate choice for your immunocompromised patients who may not be able to fully mount an antibody response. Unlike in our serological testing, CSF is more sensitive than serum. And we are working on validating PCR tests on whole blood and urine samples at the State Viral Rickettsial Disease Laboratory. These are not currently considered diagnostics or surveillance samples. However, our hope is that there is a longer viremia in these samples and we can use that for more efficient testing. So if you have a suspect, a West Nile virus patient, please collect these samples because public health may request those. The confirmatory test used most often is PAC reduction neutralization test, also conducted by VRDL. It looks for neutralizing antibodies and is capable of differentiating between flavivirus infections. So public health, your local public health jurisdiction will have samples sent to VRDL for that if you have a patient has a travel history outside of California recently, or it lives in an area with both West Nile and SLE transmission. Next slide. Thank you. So as a mosquito-borne disease, it's very environmentally dependent, and so we have a very cyclical reporting season. Disease risk starts to ramp up beginning of May, and peak mosquito activity is actually occurring right about now, around the first week of August, maybe into the mid of August if you are down in Los Angeles or Orange County, which means our peak human onset most years is late August or early September. So now is the time to be aware of it for patients potentially coming in with either neurological or just febrile illness, to consider it as one part of your differentiation. We do see some mosquito activity continuing through October, particularly again down in Southern California, but once it cools off, that will drop off pretty quickly, and we won't see much activity or transmission again until next May and June. Next slide. So current status of West Nile virus activity in California. It's pretty widespread throughout the Central Valley in Southern California. We have had 8 human cases reported from 5 counties, all in the Southern Central Valley, in Southern California. In addition, we have 2 asymptomatic blood donors that have been reported, one from Butte County, way up north, and one down in San Bernardino County. Blood donation organizations such as the American Red Cross in California and the US actually are required to test all samples from all blood donors for West Nile virus. So it is a method of detection. Organ transplants are not necessarily screened for West Nile virus, but all blood donors are. Next slide. For comparison, our SLE activity this year is so far in the Southern Central Valley and again Southern California. We do expect it will continue to spread to more counties through maybe September. We have so far just one human case reported, as a case patient from Kern County. And that was actually our first arbovirus case report of the year. And as an example of how the testing schema works, Kern County has both West Nile and SLE transmission. The initial testing found was IgM positive for West Nile virus by a commercial lab, wasn't tested for SLE, but the sample was sent to VRDL and for neutralizing antibody testing. And they found that, yes, there was a low titer to West Nile virus, but a much higher titer to SLE. So the patient was classified as an SLE infection. For most years, while we have seen the past few years over 200 cases of West Nile virus reported most years, SLE in comparison is a much lower disease burden. Since it was reintroduced to California 2016 through 2021, we had between 1 and 6 cases a year. Last year we had 16, despite having a less than the median number of positive mosquito pools. So your first differential in your brain should be West Nile, not SLE, but it is a possibility. Next slide. There is no vaccine approved for human use for West Nile virus, and there is no targeted clinical treatment. So your best tool is disease prevention, and disease prevention equals bite prevention. This is particularly important for our patients, for individuals who are at highest risk, including individuals over the age of 60, those who are immunocompromised, those with diabetes or hypertension. We recommend personal protection / mosquito bite prevention via EPA registered repellent usage, wearing loose fitting long sleeve pants and sleeves, dumping and draining any standing water, looking for containers and other sources of standing water around your property, using screens on your windows and doors and yard drains, making sure there's not holes in those, and in particular limiting activity at dawn and dusk when the Culex mosquitoes are most active. We have a lot of public education materials available from CDPH. We have both social media, digital products, as well as some physical materials like brochures. So if you are interested in obtaining some for your practice, please reach out. We'd be very happy to provide those with you. I do want to highlight that vector control is an important public health partner in California. They do extensive amounts of public education in your area. They also conduct mosquito control. They work with your local health jurisdiction at identifying the nearest cross street to the residents, and will do surveillance and treat as needed around that area. And it's an important tool for preventing additional human cases. If you're curious if you have vector control in your area or which vector control district serves your area, you can go ahead and scan that QR code, and it will connect you to MVCAC's website, where you can enter your address and find out who's going to serve your area. It could be useful for you individually as well as for sharing with your patients. Next slide. The CDC and Medscape this spring released an updated clinician training with free CME for the diagnosis and management of West Nile virus. It's maybe 30-minute to 1 hour exercise. So if you are potentially seeing these patients, I encourage you to go on there, log in, and review how to identify and diagnose West Nile virus patients. The web address is there, but of course, Google's always a great way to get to where you need to go. Next slide. And if you're interested for more information on West Nile virus or SLE activity in your area, I encourage you to check out our website, westnile.ca.gov. It's updated every Friday afternoon with the latest environmental and human activity, so you can see what's going on in your county. We also have a large number of resources, including public education materials, as well as historical records, incidents tables, lots and lots of materials available on that website. Next slide. All right, so now I'm going to move to the hot topic of everybody's interested in right now, which is malaria, which falls in the category of travel-associated mosquito-borne disease here in California. I'd like to keep it that way. Next slide. So recently in the US, it's hit the news. We've had 8 locally transmitted cases of malaria reported from Florida and Texas. Excuse me. Within Florida, there were 7 geographically clustered case patients, and there was 1 individual in Texas who do not have a relevant travel history for malaria exposure. I do want to note that there's no connection between those 2 locations, so it's 2 separate locally transmitted clusters going on in the US. These are the first local transmission of malaria in the continental US since 2003. All of the patients have been or infected with Plasmodium vivax. Next slide. So a little bit of epidemiology for malaria. It's caused by flagellated protozoans from the genus Plasmodium. There are 4 species that cause most human disease: Plasmodium falciparum, vivax, ovale, and malariae. Falciparum is the most commonly reported pathogen here in the US. However, transmission of falciparum is largely limited to sub-Saharan Africa, while Plasmodium vivax is our second most commonly reported one. It is also in Africa, but also throughout Asia and then Latin America. This pathogen is transmitted by mosquitoes from the genus Anopheles. This is a different genus than Culex, which transmits West Nile virus. Culex mosquitoes can be urban, suburban, or rural, where Anopheles tend to be more rural and in undeveloped areas. Statewide, according to vector control surveillance, over 50% of the mosquitoes trapped in California are Culex dorsalis, whereas less than 2% are Anopheles mosquito species that can transmit malaria. So overall, it is not as common of a mosquito. However, in certain areas, particularly in rice growing areas, Anopheles can outnumber Culex. But typically, if you're in a more urban area, you're more likely to encounter Culex than Anopheles. The pathogen causes cyclical fever, chills, sweats, headache, and cough. It can progress to multisystemic, severe, and occasionally fatal disease. Severe disease is most often caused by Plasmodium falciparum, but it is also likely when an individual has a parasitemia greater than 5%, if your patients have comorbidities, or if you have an individual who has never been exposed to malaria before. They're more likely to develop severe malaria regardless of which species they're infected with. 50% of the world's population lives in areas with malaria transmission. Most recent numbers from the WHO show that in 2020, they estimated 241 million cases and 627 deaths. Most of those deaths were in children in sub-Saharan Africa, which has a high endemic burden of the pathogen in their environment. Within the US, we see, according to the CDC, roughly 2,000 case patients reported each year. And except for our blip this summer, since 2003, they've all been in people with international travel or they're immigrants to the US. Next slide. Malaria is not new to the US. It was first introduced via the slave trade back in the colonial era and remained endemic through large parts of the Southeast and parts of the West, including the California foothills, until the 1940s. At that time, there were areas of California which had 50% disease burden for malaria in the foothills and some of the mining communities. However, by the 1940s, we had better diagnosis and treatment of case patients. We had improved civil engineering, a part financed by the New Deal, which improved housing as well as sanitation, particularly water supplies. And then we had improved vector control. California vector control started, the MVCAC started back in 1915, in large part to address malaria burden in the foothills. So it's been an ongoing process for well over a century now. Next slide. So by the 1940s, we eliminated endemic transmission of malaria. However, we had periodic outbreaks in California from 1950 to 1990. We had 14 multi-case outbreaks of locally transmitted in that time, malaria in that time period. For comparison, in the rest of the US, there was actually only 7 in that time period. All of these are caused by Plasmodium vivax. The first outbreak in the US since it was eliminated, and actually the largest still, took place in Nevada County. 35 case patients were infected. The index case patient had traveled from Korea. It went camping at a little lake slash pond in Nevada County. And that area was surrounded by campsites, campgrounds that are owned by Campfire USA, which is an all-girls camping program at the time. And over the next few weeks, 35 people became infected, including 27 campers. There hasn't been an outbreak this large since 1952. So 70 years, we've kept it to under 35. I also wanted to then look at our last 4 outbreaks in California from 1988 and through 1990. All 4 of them were in San Diego County, and at least 39 case patients were identified. The consistent note between all 4 of these outbreaks was that the index case patient and the most case patients who were identified were migrant farm workers. And within all 4 of these outbreaks, the farm workers had inadequate housing, occasionally no housing. They were just sleeping out in the field with a lack of sanitary water and wastewater treatment. And the consensus was that they also lacked access to medical care, which might have identified the outbreak earlier and prevented spread. Next slide. We haven't had a locally transmitted case since then. In the last decade, we have a median of 102 cases per year. Pretty close range on that. Our max was 134 in 2017. 2020 was our minimum of 45, which is not surprising because that was first year of COVID when travel really locked down. So far this year, we've had 23 cases reported. Those numbers will continue to go up through next summer because of reporting delays. And so far, all of these cases are travel associated. Next slide. Within California, in that past decade, individuals are residents of 40 different counties. However, the greatest disease burden, the highest concentration of cases is in Southern California, in the Bay Area, and Sacramento. This is because these are highly urbanized areas where we just have our largest populations and where many immigrants end up. Next slide. And in terms of where these individuals were exposed, over 70% of our cases had exposure in sub-Saharan Africa. We have other travel-associated mosquito-borne diseases such as dengue and Zika, and we have a much broader distribution, but that's because malaria is so endemic in sub-Saharan Africa. But we do get cases reported from really everywhere that malaria is reported globally. I want to highlight that within Latin America, there is transmission as far north as Mexico and parts of Mexico, but not along the US-Mexico border. In the Caribbean, there's only transmission in Haiti and Dominican Republic. And with the Afghan refugee situation, we have seen an uptick in individuals with exposure in Central Asia, and occasionally individuals who immigrated from Central Asia to South America and then overland up to the US. So assigning exposure can be really complicated with many of these refugees or asylum seekers, but we do our best as epidemiologists. Next slide. Diagnosis of malaria, the gold standard is microscopy, which is a thick or thin blood smear from capillary blood or venous blood. It's important to take a sample of this before you start any treatment. And lab technicians are typically able to identify morphological features, and it can be quantitative. They can determine the parasitemia. And it looks like I'm getting my time. Can be challenging to read. PCR is also useful. There is a commercially available rapid diagnostic test, but should be paired with microscopy and PCR because it's much less sensitive. Next slide. Prevention, there's a number, general mosquito prevention, there are a number of medical medications available. CDC has some really great information on selecting prophylaxis. So if you have patients that are going to be traveling, I really recommend checking out the CDC's malaria website. Next slide. Same thing for treatment. It should be initiated as soon as possible. Drug selection can be really challenging. The CDC has a malaria 24/7 hotline available for healthcare providers to help you decide the most appropriate treatment. But IV artesunate is the first line treatment for severe malaria, and the US manufacturer does maintain a 24/7 hotline as well to help you identify distributors. And if you just want a general drug to keep in stock, that would be appropriate for all Plasmodium species and safe for children, pregnant individuals, CDC recommends artemether lumefantrine under the commercial name Coratem, which is manufactured by Novartis. And I believe that was it. Next slide. Yes, I'm done. Sorry about that, folks. Did my best.
Well done, Mary Beth. Such an information-rich session today. Unfortunately, we don't have any time to answer any questions, but we got a lot of questions answered. Jenny, Erica, and Mary Beth, I want to thank you so much for presenting today's content, and thank you all as usual to everyone listening in. Just as a reminder, you'll all receive a survey about 5 p.m. today. You can attest your attendance, and when you complete that, we'll send out your CME certificates. Those will come in about a week. And also included in this email are instructions on how to access the recording of this webinar, so please do share that widely. And just as a reminder, Tuesday, September 12th is the next session of our series. We'll be doing a lot of conversation about the newest communicable disease guidance for schools and some vaccine preventable disease information for children specifically that we haven't talked about today. So thank you all again. Have a wonderful day, everyone.